Hi Ninja Nerds, in this video we're going to talk about blood transfusion. If you like this video, please give it a thumbs up and subscribe. Let's get started. So the blood transfusion, one of the biggest things that the NCLEX and nursing school likes to touch on and quiz you on and ask you questions about, let's talk about it. So packed red blood cells. We're going to be talking and focusing on RBCs or packed red blood cells today. There are many other types of blood product transfusions that we can give patients, but typically when the NCLEX is asking questions about a blood transfusion, we're talking about packed red blood cells. So, red blood cells, what are they? RBCs are carrying mechanisms of our body. So we have the outline right here, which is the biconcave. So we're looking at a side view of the red blood cell. But let's also talk about the anatomy of the red blood cell. You guys remember what the purpose of a red blood cell is? So we have these blue molecules in here, right? And what are those? Do you know what those are? Those are O2. That's oxygen, right? And red blood cells are carrying carts of oxygen. So we're looking at that, and we're looking at this little image right here that I drew. And we have lungs and we have the body, right? So basically, we have red blood cells that go through the lungs, and they're carrying O2, rich blood, to the body. And then the body uses that up and gives us our waste product of CO2 that our lungs exhale out, right? So we have this exchange. Our red blood cells are allowing us to carry oxygen to our blood and our CO2 out. I always like to think of red blood cells as a little train car. There was a professor one time that mentioned this to me. So I think of every one of these carts as a red blood cell, right? So this is a red blood cell, this is a red blood cell, and this is a red blood cell, right? And this is how I explain to my patients when they're like, I don't understand what's going on. So red blood cells have the ability to carry, we know, 4 oxygen. So each one of them has 4 oxygen, 4 O2s. And when we start to lose oxygen, right, when we start to lose red blood cells, so we lose a red blood cell, we lose a red blood cell, right? So we're going to cross these out. When we lose them, we lose the ability to carry oxygen. So our oxygen is becoming depleted. So now we have less red blood cells, we have less carrying capacity of O2. So what are some of the causes of us losing blood? One of them is just strictly blood loss. And what can that come from? That can come from surgery. That can come from some sort of trauma, right? So we're just losing blood. There may be other issues going on, spontaneous types of bleeds and ulcers and things like that we can also lose blood through. And people that are on thinners typically tend to lose blood a lot quicker. What's another cause? What's another type of blood issue that people can have that can make them actually have low O2 carrying capacity? It's not specifically they're losing red blood cells, but they're losing that carrying capacity mechanism. That is anemias, right? So we have blood loss, we have anemias, and then we have some problems with signs and symptoms, right? So we have a patient that's either losing blood, they're anemic, and they're having this low O2 carrying capacity. So what are some signs and symptoms of somebody with a low O2 carrying capacity, a low red blood cell count? The first one's going to be shortness of breath, right? They have low O2, they're going to feel short of breath. They're going to feel tired, or another word that we use, fatigue, right? So they're going to feel fatigued, they're going to feel short of breath. Our oxygen is low, our muscles in our body aren't getting that oxygen that we need. What else is going on? They may have, what's this right here? We have a little blood pressure cuff. They're losing blood. What's that? Hypotension. So the patient may have some hypotension. And we know that if a patient is hypotensive because they're losing blood, and if it's been going on long enough, it's pretty severe, what's a compensatory mechanism that shows up in another vital sign? What's this right here? Elevated heart rate, tachycardia. So they're going to have a high heart rate. So your patient's short of breath, fatigue, they have a high heart rate, they have a low blood pressure. What's another thing that's going on? Remember, these patients have low blood, right? So you're going to walk into your patient's room, you're going to be like, yo, I mean, I don't know if you know what's wrong with him yet, but this guy is looking pale. He is white as a sheet in there. He's definitely got a low hemoglobin, right? So then we check hemoglobin. Typically, if it's low between 7 to 8, that's when we want to transfuse. Remember though, this can vary on the patient. Remember that males are 14 to 18. That's our value that the NCLEX likes to use. And our females are 12 to 16. Right? So we have these patients. We're looking at them. They are blood loss, probably from surgery or something else that's going on in the body that we don't know yet. We're going to further test for. They may be anemic. They are short of breath. They're pale. They got everything else going on, and their hemoglobin's low. So the doctor's like, yeah, listen, we don't know what's going on yet, but this guy's going to need some blood. All right, so now we know that the patient needs a blood transfusion. You're going to go into the room, and you're going to be like, hey, Mr. Weasley, do you know what's going on today? And they're going to say, yeah, the doc was just in. I'm going to be getting the blood transfusion. You're going to look into the chart, and you're going to say, oh, yeah, I see you signed consent. Great. Then you're also going to look into the chart and see there's a doctor's order. Fantastic. All right, so the patient's got consent signed. They got a doctor order, and we're ready to start moving forward to get ready for this blood transfusion. So the next thing we're going to do is we're going to get 2 IVs in this patient. Why 2 IVs? First of all, the type of IV we're going to need is a large bore IV. Right? So large bore, what does that mean? Typically anything bigger than a 20 gauge, all right? So 20 is great, ideally the 18, right? And why is that important? Why do we need 2 IVs that are large bore? The reason we need this is because when red blood cells travel through this tubing, through the IV into the patient, they need a big enough hole to fit through. And if we're giving them something smaller, like a 22 gauge, something that's tiny, the red blood cells have a very, very good chance of lysing or breaking apart and going into the patient. And we're going to be giving a patient red blood cells. We don't want to be giving them broken ones because that's not going to help anybody. So these patients, we want to make sure, are getting a 20 or an 18 gauge, specifically 2, to allow for that blood transfusion to go smoothly. But why do we want 2? Why not just put 1 IV in? We need 2 because there's nothing else that can go together with blood. Okay? Nothing can go together with blood. All right? So, with our blood, right? Nothing can go with the blood. We have our 2 IVs, and we're going to send off a type and screen. Type and screen, TNS. We need to know, are they O positive? Let's put a question mark. Are they AB negative? Like, we don't know. We got to find out what their blood type is. Then we're going to go through and ask them, do you have any allergies to any type of things that we should be aware of? Have you ever had a blood transfusion before? And they're going to say yes or no. If they say yes, you're going to say, did you have any problems with it? Did you have any things that we should know about? No, you didn't have any problems? Great. You want to also make sure at this point you ask them, do they have any objections, right? Because we know that Jehovah's Witness, they don't want any blood transfusions. And it should have been covered with the doctor. However, you are a nurse and you have a license as well. So you want to make sure you're asking them, do you have any objections to getting blood products? After that, we want to get a full set of vital signs. We want to make sure that we also get a temp, right? People always forget the temperature on a full set of vital signs, so make sure we're getting that. You want to assess the patient. So when we assess them, we're going to be essentially looking for signs of a transfusion reaction before the transfusion has started. That way we're noting that there is no problems with the lung sounds, right? So we're going to listen to their lungs. There's no rash on the body, and all their vital signs are normal, okay? So we're assessing for that reaction through our patient right now, and it should all be negative. However, sometimes patients have a temp. They got something else going on as well. So if the patient did have a temp, if you check it in, it's like 101.6, right? And you're like, hey, doc, before we do this blood transfusion, this patient's got a temp. Do you want me to give Tylenol? Would you like to order Tylenol? Typically, they'll say yes. So you'll give them Tylenol. Probably wait 30 minutes. Recheck it, and then go from there. Okay? Can't really start a transfusion without any Tylenol, with a temp. So give them some Tylenol. There also might be other medications that you give the patient. So we gave them Tylenol because they had a temp. What's another medication that you might give somebody for a pre-procedure for a blood transfusion? Especially if they've had a reaction before where they've gotten a rash or they've had any other histamine reaction. What is an antihistamine that we can give? You guys know it? It's Benadryl. Give a patient Benadryl beforehand as well. It's their pre-blood transfusion med, and that way we're going to be able to make sure that this transfusion goes nice and smoothly. The last thing, we gave them meds. We've checked their history, their allergies, the type and screen. They got 2 IVs. We got everything at bedside and we're ready to roll. We're going to call the blood bank and say, hey, we are ready for that blood, because you know that when that blood arrives, you only have a certain amount of time to start that transfusion. So you told your friend, you're like, hey, I got a blood transfusion that's going to be going on. Can you help me set up those units? The blood arrives and you have how many minutes to start? You've got 30 minutes, right? So that blood comes and you're ready to set up this, do your RN checks and set up this blood transfusion in that 30 minutes. Otherwise, you're going to have to send it back. Why? When that blood is taken out of the fridge, it has a very, very big chance of developing some type of bacteria, especially when it's 30 minutes out of the fridge plus the 2 to 4 hours that it's hanging. It could develop some type of bacteria in that blood bag and you're delivering it straight to your patient, and then your patient could develop septicemia, some type of blood infection. So we want to make sure that we are hanging this blood within 30 minutes, and if we don't, we are sending it back to the blood bank. All right, let's move on to setting it up. The blood has arrived and we're ready to start our 2 RN check for our blood transfusion. So remember, Ninja Nerds, every policy and every hospital has a different policy. Just make sure you know where you work and what your policy is for that institution. Where I work and where the NCLEX is going to ask questions is the 2 RN check. So remember, where are we hanging blood, and we're going to do a 2 RN check. And what are we checking for? The first thing is you're going to check again for that order. Okay. Want to make sure the patient has an order to get a blood transfusion. Okay. If it's not there, make sure you contact the provider and just say, hey, you didn't put that order in. But typically, you won't get the blood from the blood bank to transfuse without an order, because they need an order as well to send it up. So you have the order, great. Then we're going to check the patient. We're going to be checking their name, right? Their date of birth, and their medical record number, or their MRN. Okay. So you're checking that both, either someone's reading the bracelet and someone's reading off the blood bank paper, because that's how my institution works, or someone's reading off the computer, making sure you got the right patient, the name and date of birth. Then we're going to be checking the blood type of the patient, and we're going to be checking the type of the blood that was sent up. You want to make sure that these are compatible, okay? What else are we going to be doing? So we have our name, date of birth, and MRN, good. The type of the patient and the type of blood. Now we want to make sure that the blood sent up is also the order. So you're going to be checking the unit number of the blood. And then what's the most important thing? I mean, they're all very important, but we want to make sure that this blood is not expired. So you want to check the expiration date. Okay, so the order number is good, right? We got an order. We got a name, date of birth, and MRN, all good. The type for the patient, their blood type, and then the type of the blood, all good and compatible. Fantastic. The unit number, and then the expiration date. All that looks great. However, you noticed maybe in the patient's name, they didn't have the middle initial or something. Something wrong. If there is anything wrong, anything, what are you going to do? You're going to send it back, right? If the salad comes on top, I send it back. So you're going to send back this blood. You're going to send it back to the blood bank. You're going to say, hey, there's something wrong. You know, there's initial wrong, the date's wrong, the birth date's wrong, the expiration date's wrong. You're going to send it back to the blood bank and let them know. Say, hey, I'm sending this back. Then tell the provider, hey, we sent back the blood. It was wrong, so we can't start the blood transfusion. Is there any other orders you want to put in the meantime? So the blood was sent back. Great. But maybe we didn't send it back. We don't send it back. Everything is good. We have blood, the 2RN check, and now we're ready to start our blood transfusion, right? So let's start our blood transfusion. What's the first thing? We got to set it up. So I have this drawing right here. We have our most important thing right here that we're going to need is our Y tubing. Okay, remember we need the Y tubing with the filter. Okay, which you can see right here. It's the filter in the middle there. We need that Y tubing with the filter. Why? Why is that important? That filter is going to help filter out anything that is too big to go into our patient. Okay, making sure that the blood's good, okay? So you're inspecting the blood, you got everything, you got your Y tubing, and you have what's up here, our normal saline, right? 0.9%. It's the only thing that can go with our blood transfusion. So they ask you on a test, I hang lactated ringers with blood. That's incorrect. It's wrong. Don't do that. Only normal saline. Remember, that's why our patient has 2 IVs. We want to run blood and blood alone through 1 IV. So that other IV, run whatever you want through it, okay? But not with the blood. Blood is its own, it's hogging that IV. It's just hanging on its IV. It's its only spot. So we have our Y tubing, we have our normal saline, we have our blood unit, and we have our pump. Now we're going to be able to set up our blood transfusion. Take the Y tubing out of the package, and you want to make sure we clamp. 1, 2, 3. There's 3 different roller clamps. You want to make sure you clamp them. Okay, clamp them all. Great. Now they're all clamped. Now you're going to have your normal saline. You're going to spike your normal saline. You're going to open this one. So now this one's open. And then you're going to open this one. And that normal saline is going to flow through, and it's going to fill in our chamber here. You're going to give this chamber a couple squeezes, right? And that's why it's marked number 5, because we're going to focus on it, and we're going to make sure this filter, this line of normal saline, gets right above that filter, about halfway. Great, wonderful. Then you're going to have probably your cartridgette that goes in here. Make sure you fill that completely. And that's usually where I stop. I usually stop it when the fluid kind of gets around here, past that cartridgette that's going to go in the pump, past the filter. Then I'm going to clamp again, I'm going to clamp again, and I'm going to spike my blood. Now my blood is ready. We checked it, we're ready to roll. So the last thing you do is you're going to spike your blood, and you're going to let the blood start running through, right? Maybe we should do this in a blood color, right? So our blood is going to start coming through. We're going to unclamp this and unclamp this, and as it comes through, you'll see it start mixing. And then once it makes it to around the cartridgette, that's where you can like stop, okay? You can clamp everything again. So we clamp it and we clamp it. So everything's clamped, it is primed, and ready to start that transfusion. So remember, we said this before, we have to start the transfusion within what? 30 minutes. Okay, so you want to start that transfusion within 30 minutes. And there's another thing we need to remember is that it needs to be finished, and I said it earlier if you were paying attention, it needs to be finished within. How long can that unit actually be running for? Do you know? It's 2 to 4 hours. Okay, so you want to make sure that it's running within 2 to 4 hours, because if it's not, and it's not finished, they can get that septicemia, they can get that issue with their blood again, and we want to make sure that they're not getting sicker. We want to make this patient better, right? So everything is ready. We're going to put our cartridgette into our pump here, and we're going to set our pump, okay? Nothing's attached to the patient yet. We're not running it yet. We're just going to set our pump up. Typically, if the patient's had a blood transfusion before, or they're used to it, or they've never had a reaction or anything, you can run it a little quicker. But remember, the bag of blood usually has somewhere between 350 milliliters of blood, maybe a little less, maybe a little more. Okay, so when it's got that 350, and you need to run it over, 2, 3, 4 hours, in your head you can be like, well, all right, somewhere between 100, 150, it can run it. I typically start my patient right around 20. You want to start them low, 20 milliliters an hour. So start low. Why? Why are we starting low here? You want to start low. You're going to be sitting with this patient for about 15 minutes, right? So when you start it low, they're getting a little bit of that blood. So if they have a reaction, you can stop it right away. You're not flooding them with a bunch of blood, okay? And then they're gonna have this huge reaction. So we got it, the tubing primed, we got everything ready, we got our pump ready, and now we're gonna quick get our vital signs. The first thing we gotta do before you even attach that blood is get that set of vital signs before. And then you have to stay with your patient for how long? You're gonna stay with them for at least the first 15 minutes. Why? Why are you staying with your patient for the first 15 minutes? There is evidence that if a transfusion reaction is going to occur, it's going to recur in the first 15 minutes. After that, the patient's pretty safe. So, You're going to stay with the patient. You did their vital signs before, and now we're ready to start. So we hook up the transfusion and we start it. And we're going to be teaching the patient about some of the reactions that they may be looking for. So you want to keep in mind that you're like, okay, just tell me if you have some of these reactions, which we'll talk about. But these vital signs, we did the first set before, right? And then you want to do a set at the 5-minute mark. You want to do a set at the 15-minute mark. Okay? Now you're 15 minutes, right? With your patient, you're done. You can set your monitor then for a Q 30 minutes for 2. And then after that, it can be Q 1 hour until it's done. All right, so our vital signs before, at the 5-minute, the 15, the Q30 for 2, and then every hour. Keep this in mind too, this is just like a little standard. Every facility and every policy is written a little different, so just make sure you're aware of your policy. So your patient, you started the transfusion, and all of a sudden they start complaining of some type of reaction. Let's talk about what are those signs of those reactions. We're at signs of a reaction. So our patient may be having a reaction, and you want to make sure as a nurse you know what those signs are. Okay, some aren't as apparent as others, but you also want to make sure that you let your patient know, like, hey, if you're feeling, X, Y, and Z, just let me know so I can come in and check you out. So remember, we did a little assessment beforehand, but we're going to look at this guy right here. And Mr. Weasley, he's not doing so hot. He's got a lot of things going on here. First thing we see right here is he's complaining is, I'm itchy, right? So we're going to be looking for either itchiness. So are they itchy or do they have a rash? Okay, it's a big sign right there. So itchy or rash. What's another thing? We're looking at altered mental status. They start acting goofy, they start acting confused, they start saying things that you're like, this is weird, you were alert and oriented, 10 minutes ago, what's going on here? Okay, it's another sign of a reaction. What else we have here? There's little beads of sweat. Right, he starts sweating. You're like, oh boy. No bueno. Oh no. We got something else going on here. He's got a headache. Right? Or he's nauseous. He's got the nausea, or as we used to say in my nursing class, nausea, because we could never spell it. He's got nausea. He's nauseous. All right? What else? What's this thermometer here? Why are we always taking a temp? Right? All of a sudden he develops a fever. Why did my handwriting change? I don't know. Yeah, so he developed a fever. He's got this rash. He's got this nausea. He's acting weird. He's sweaty. All these signs of reaction. Couple other things. Chest pain. Starts complaining of chest pain, or another one is a back pain. All right. Why back pain? That's interesting. It's because you got kidneys back there. Remember we talked about the IVs? We talked about them being really big. Where are some really, really small vessels that blood has to transfer through, right? It's the kidneys. We know there are erythropoietins made there, making our red blood cells, and they can get caught there, and caught in that back, right? Or he's got chest pain up here. Ooh, it's chest pain right here. The last thing is, what's this? What's this little thing with lightning bolts? Harry Potter? No, maybe. It's cramping. Why cramping? Well, maybe the patient's potassium is a little different now. So we're getting some muscle cramps. So this patient's got a rash, altered mental status, headache, fever, chest pain, back pain, cramping, all this stuff going on. Some of these things maybe can be fixed with medication. That's why we got the other IV, just say, oh, he's a little nauseous, give him some Zofran, make him feel a little better. But if it doesn't get better or something else is going on, you notice, 2, 3, 4 of these things, what are you going to do? You're going to be like, oh no, my patient's having a reaction to this blood transfusion. It's happening. Everybody, it's happening. And you're going to what? You're going to walk over and you're going to say, everything's okay. I know exactly what to do. I'm going to stop the transfusion. Walk right over to that pump and say, stop. Okay? Press on hold, detach it from the patient, and you can take it out of the room, take it off the IV pole, off the pump, and you're going to put it in the biohazard bag. Okay. While all this is happening, you're also going to start normal saline. all right? Why are you going to start normal saline? You're going to start it so that you can protect that IV, okay? You want to make sure that the IV stays patent, okay? Okay, you want to make sure the IV stays patent so we have it in case something else goes on, or in case this reaction gets so severe, even though we stopped it, that they start needing other type of intervening interventions, okay? So you stop the transfusion, you put it in a biohazard bag, you're putting normal saline on, and you're going to call the PCP, or the HCP really, the healthcare provider, and you're going to say, hey, this person's having a transfusion, what do you want me to do? And hopefully they're going to put in new orders, whether you're going to keep running the transfusion, or you're going to give new medications and then restart the transfusion. And then you're going to call the blood bank and just say, hey, FYI, I'm sending this blood back to you, okay? And let them know that the blood is on its way back. All right, so the blood is now back at the blood bank. Your patient's having a transfusion reaction. You've called the provider, you've got IV in sight, IV patent, and you're waiting for those new orders to come in. There's one other thing that the facility typically wants you to do, and this isn't to get you in trouble. It's nothing like that. It's to make sure that we have this noted in the patient's chart, as well as ways that we can prevent it. And it's your way of proving, hey, I did everything right. You know, I took it off, I sent it back, I called the provider, is you will need to file an incident report. All right. Because this is a reaction that could have caused a lot of harm to the patient. But luckily, you being a great ninja nerd nurse, you were able to stop it before it got too severe. So you did all these things, you gave the meds the new orders, whether it was just to give them some Tylenol or just give them some Zofran, or making sure anything else is normal. You're going to reassess their vitals, get a new set of vitals now, and just stay with your patient. Stay with them. Stay with them for a little bit and just make sure that they're doing okay and that the reaction, now that the blood transfusion has stopped, their reaction's getting better, or not getting better, they're not having a reaction anymore. And that's what you're going to do with this patient to make sure that this signs of the reaction is better and not worse. Ninja Nerds, in this video we talked about blood transfusions. I hope it made sense, and as always, until next time.